when I came up with the schedule of didactics for this year, this date was going to be neuromodulation, but as things turned out, this was too big of a topic. So as I was putting things together, I realized we should just focus on electroconvulsive therapy. So we're going to do that. And I'll tell you the story. My father is a veterinarian, and since as early as I can remember, I've been helping him in his veterinary practice, which was in those days large animal practice, and it involved a lot of blood, guts, and gore. So by the time I was in medical school, I had been richly exposed to all sorts of really unusual or disgusting things. I had a very high tolerance for the things that would make medical students nauseous. And I went through medical school with really only 3 things just churning my stomach. And one of them surprised me. It was the first time that I saw ECT being done at a large academic medical center. There was no blood, there was no guts, there was no gore, there was no screams of anguish. There was nothing about this I was surprised about it, because there shouldn't have been anything that was really stomach churning about that. But I remember thinking, this is barbaric. We're going to then stimulate, we're going to create seizures in all these people. And it struck me that we could probably have done much better. But I quickly came to embrace this technique, because one of these patients that I saw in my early days of medical school was a patient I was following, and he had severe depression. He was catatonic. He had lost nearly 50 pounds. He was developing bed sores. He didn't talk. He didn't move. And this had been going on for a very, very long time prior to him coming into the hospital. Every time as a medical student, I would go in to see my patient, and it was just a man with a pained look on his face, not moving in his bed. Within 2 treatments of ECT, he began to move. One day I came in and he was standing up. By about treatment number 4, he was talking. Whereas he was initially mute, by treatment number 4, he was talking, but he was talking like a depressed person. I'm just sitting here thinking about all the bad things that I've done. By treatment number 6, he was getting his appetite back. At one point he said, I think I could use a steak. Can you get me some food? And then by treatment number 9, he had no more depression. His life was restored, and he was amazed that such a long time had gone by in which that he had lost due to his depression. So it was astounding. Key point: his doctors prior to the ECT had tried many, many medicines, and he had gone with debilitating depression for over a year. And we got him better in 3 weeks, and not just better, we got him into remission. So it's a technique I think it's worthwhile to talk to you all about, because it's something that not a lot of clinicians actually practice. Believe it or not, it's not something that a psychiatry resident has to demonstrate proficiency in by the time that he or she graduates from residency. It's a technique which is largely misunderstood, and for many good reasons, still surrounded by a lot of stigma and a lot of detritus from when it was done in a very bad way. And I will say it is not, like everything else we do, it is not something for everybody, and it certainly has side effects and risk, and it is indiscriminate. We stimulate the whole brain to have a seizure, but it remains a irreplaceable technique. So let's talk briefly about how we got to this. For as long as we've had human beings, we've had epilepsy in our midst. We've also had psychiatric disorders like psychosis and melancholic depressions. And you can certainly have people that have both, a severe psychiatric issue as well as an endogenous epilepsy. And when physicians have observed such patients with co-occurring psychiatric disorders and epilepsy, we've seen throughout the millennia interesting things happen. There's a there's a very significant overlap between seizure disorders and psychiatric disorders. One of the things that we've noticed since we've had anticonvulsant medications is a phenomenon called forced normalization. This means that when you force seizures into remission, typically by giving medications, but you can also force them into remission by brain stimulation techniques or certain types of neurosurgeries. When we put seizures into remission, we can actually cause for the first time an onset of psychiatric symptoms. Typically, they take the form of psychotic symptoms. So it seems as if suppressing one area of the brain produces symptoms in another facet of it. The converse of that is that we also see people that have psychosis, and that they will have a spontaneous remission of psychosis when they have one or more seizures occurring in short order. And it's probably that phenomenon. People with the typical pattern is you have some small degree of psychotic symptoms and they get worse and worse and worse. Then you see a set of seizures, you see a remission. That kind of pattern has been observed again, probably for millennia, and physicians across the world and in many different points of history have come up with the same idea, that maybe we can deliberately cause seizures in order to affect the resolution of severe psychiatric symptoms. In the history of ECT, there's always a reference to using an electric ray as a way to create shocks, and that was used as an attempt to treat headaches. But aside from that, when physicians at various points in history, at various locations across the globe, have attempted to induce seizures, they've done it by using drugs or medicines. And actually, the only difference between a drug or a medicine is whether you're using it for a therapeutic purpose. They're both chemicals, whatever you name it, they're chemicals that interact with life functions and produce symptoms. Or as I also like to say, all drugs are poisons, and that we call them medicines when we try to use the poisons in a judicious fashion to effect a better outcome. But aside from that, the typical drugs of choice in those days were strychnine and camphor, and according to the reading, patients that would take these drugs would the procedure was take some more, and prior to the onset of seizures, there would be like these auras, there would be nausea. It was a very unpleasant experience, and I assume that physicians kept doing it because they saw on the other side of that some benefit to counteract the discomfort. By the 20th century, we had the idea, collectively, we had the idea that we could skip the drugs and maybe just directly cause seizures by applying electrical currents to the brain, and that's how we got modern ECT practice. And it did work for some people, but it was really it devolved quickly into a horror show. With a first pass, we just had these electrodes, and there was no understanding of what's going on. So essentially, plug it into the wall, put it on the head, and make the seizure happen. It was talk about indiscriminate. It was very indiscriminate. Also, we didn't have a really great system of categorizing mental illness. So physicians of the time saw that clearly some people that underwent this procedure had very good end results, but we did a very poor job at recognizing which symptom clusters were actually going to respond to this treatment. And it was applied to all sorts of patients, regardless of symptoms. And the ones that didn't respond were in the hands of less sophisticated clinicians. Non-response to the initial round of ECT was seen as not as this patient has got an illness, not responding to the treatment, but we should just give the treatment more often. And so it was overused and indiscriminately used, and brutally, it was given when patients were awake and conscious. Electrodes were put on the brain, electricity was turned on. Horrible. And to add injury to injury, shortly after ECT was introduced, we had this idea that we could sever some connections between the frontal lobe and the rest of the brain, this technique called frontal lobotomy. And the procedure was give an electrical stimulus to make the patient post-ictal, and during a post-ictal state to do the lobotomy. altogether horrid. And that those really awful events cast very long shadows, to the point that even to this day, the state of Oregon, in its administrative code, regards ECT as I think they call it cruel and unusual practice, and it is in the code listed alongside of forced sterilization and lobotomy. And that's probably why we don't force all of our psychiatric residents to demonstrate proficiency in this technique, because it remains controversial. But when I was doing an ECT practice, every single time I had a case, medical students and residents would say, I want to see, I want to see. And in the end, they would say, that was it. Because in modern practice, we're doing it much better. Everybody gets a general anesthesia, and following anesthesia, they get succinylcholine typically to induce muscle paralysis. Thus, we eliminate the convulsive part. So I assert that we should call this electrotherapy, because we're actually not producing convulsions. Electrical stimulus is really, it varies, but on average, it's like 6 or 9 seconds of very brief pulses. During those 6 seconds, most of the time, there's no charge being passed between the electrodes. So very brief pulses of electricity with just enough energy to excite the neurons in the circuit. And once we stimulate the brain to have a seizure, the brain's undergoes spontaneous synchronized discharge, aka generalized seizure. For between 30 and 60 seconds, brain runs out of energy, electrical activity of the brain goes quiet. Following that, we give medications to manage the autonomic, the sympathetic nervous system response, I will explain in a second. And we've seen that if we repeat this procedure 2 or 3 times a week, typically 3 times a week, that we can affect remission of symptoms in people with severe depression. And remission, just to be clear, means essentially symptoms are at minimal levels or entirely gone. And sometimes we can see remission in 6 treatments. Occasionally we'll see it have to go to 12 treatments, but there's a very strong modal number of about 9 treatments required to induce remission for melancholic depression. So I mentioned this autonomic response. I want to talk about that. The vagus nerve is a cranial nerve and is part of the parasympathetic nervous system. Because the vagus nerve originates in the brain, when the brain is having synchronized electrical discharges, aka generalized seizure, the vagus is also discharging its neurotransmitters, and the vagus runs from the brain through the gut. It passes across the heart, and with each discharge of the vagus nerve, it's releasing acetylcholine on the heart's SA node, and the effect of acetylcholine on the SA node is to reduce the rate and force of contraction. In some cases, you can actually have many seconds with no pulse because of the very strong acetylcholine effect. When the seizure is done, that parasympathetic signal stops, and meanwhile, the baroreceptors in the body have picked up a substantial drop in blood pressure, which then triggers a sympathetic nervous system response. There is, as a reminder, no direct innervation of the sympathetic system on the heart. Rather, the adrenal gland releases epinephrine and norepinephrine, circulate throughout the body, and that's what causes the heart to have increased rate and force of contraction, with resulting increases of blood pressure and pulse, and those increases can be very substantial. Which leads to the discussion about what are some side effects or potential complications of ECT. When I counsel patients about this, I break them into, there are some common but nuisance level side effects, and there are some side effects which are serious but are extremely rare. In the more common nuisance level side effect, we have headaches and nausea. I should have put in here that although the body is paralyzed with succinylcholine, electrical stimulation will cause the muscles of the head to contract. So you have a tendency to scrunch up the facial muscles and the jaw muscles during the electrical stimulation. That can result in some intense biting. So we put a foam block in between the teeth, but if the block slips out, there could be biting of the lips or tongue or chipping of the teeth. So I should include that as a actually, it's not that, it's not a common side effect, but it's a possible side effect. And then there is, during post-ictal states, there's going to be confusion. The day following a seizure, there's likely to be a low energy and difficulty forming memories. And since we're doing this 2 or 3 times a week, it's quite common that during the period of ECT stimulations, people will have patchy memories, or memory won't function like they're used to. That, as I'll talk about in a slide down the road, goes away when the treatment is done. Then we come to very rare but potentially serious, and here we see the effect of that sympathetic reflex. So when you have very high pulse and very high blood pressure, the heart muscle has to do a lot of work, which requires then a lot of oxygen. And if the patient had some pre-existing blockage of coronary arteries, the possibility exists that the heart muscle won't get as much blood flow as it needs, and you can have ischemia or infarction. We minimize this risk by doing continuous EKG recording during the procedure, and it is very rare that you see EKG changes suggestive of ischemia, but it is a possibility. Even more remotely possible is that with this surge of blood pressure, you have increased intracranial pressure, and intracranial pressure, with the surge in pressure, could result in the bursting of aneurysms. And also with the increasing intracranial pressure, if the person had a lesion like a brain tumor present, that could create herniation injuries. So we do things to minimize those risks. As I mentioned, we put soft cushions between the teeth to minimize dental injuries. We use extremely brief electrical stimuli with just enough energy to cause the seizure. So we calibrate the stimulus to try to reduce total energy exposure. And in doing so, we can greatly reduce the cognitive side effects from this procedure. We can also minimize cognitive side effects by applying the stimulus to the non-dominant hemisphere. Typically, that's the left hemisphere. And so you can do that. Some clinicians will do a cardiology consultation across the board. Others will call cardiology if they have any hint that there may be some cardiac risks. Cardiology usually says you can go ahead and do it, but they'll recommend being more vigorous with trying to prevent the pulse and blood pressure responses. And we will use these drugs liberally to try to mitigate those problems. And we can do head or MRIs, head CTs or MRIs in order to rule out the presence of those tumors or things that are creating increased pressure. So, those are the effects and what we do to minimize them. Because memory gets the biggest, is one of the bigger ongoing concerns with this procedure. Let's talk about that some more. I mentioned that there's short-term disruption of short-term memory during the course of treatments. Most data and all clinical experience says that those things go away, memory recovers once the procedures are done. There are some people out there that will say that they have lasting cognitive or memory deficits as a result of ECT that was done 6 months ago or 6 years ago. That's an area of controversy. A number of studies have tried to look at long-term measures of cognitive functioning following ECT, and many of those studies don't find a great signal for cognitive impairments at great distance. Nonetheless, if you ask people if they perceive cognitive problems, you'll find that segment of them that do say that. In one study from Sweden, they found that there was some correlation between expectations or fears of cognitive impairments and the existence of them down the road. So there's a lot of logistical problems, a lot of logistical considerations that make it very difficult to get definitive answers to this concern. So at this time, we can say that a lot of data says that we can't find those things if we go looking for them. but other data says that some people do complain about this, so it's something to counsel as a possibility when we engage in informed consent discussions. So we talked about all the bad things, and let's come back to why we'd even come up with this idea in the first place. And that's because if you look at all depressions, you see success rates of between 60 and 90%. If you parse that out into the melancholic subtype, the kind that involves sleep disturbances, well, the kind that involves insomnia and or early morning awakening with loss of appetite, loss of weight, and a profound slowing of psychomotor activity, that kind of depression, you get remission rates that are around 90%. So that is outstanding when you consider that the next best treatment is transcranial magnetic stimulation, and that has a response rate, not remission, response rate of about 30%. And when you look at in the STAR-D trial, which was a large systematic and naturalistic study of antidepressant response, by the time you failed 2 antidepressant medications, the likelihood of a response to the third, again, response, not remission, the likelihood of response to a third agent is about 15%. So 15% for medicine, 60 to 90% for electricity, and you can see why we would have these discussions and why I want to talk to people about this technique. In addition to the extremely well-documented use in severe depressions, it also has very good success rates in manic episodes that have not responded to antipsychotic drugs or lithium or Depakote. And there's also, it's clear that some people with schizophrenia will have very good therapeutic responses to ECT. Remains to be worked out exactly which kind of person with schizophrenia may best benefit from that. So it's an ongoing area of investigation. But to be clear, science says that there's something useful there, even though the state of California legislature says you can't do it for people with schizophrenia. So why does it work? Well, we come down to, I'll tell you, we don't really know why anything works. If you talk about antidepressant medications, they inhibit the reuptake of serotonin. Great, but how does that translate into antidepressant relief? That's where things get sketchy. What we know about ECT is that we do know that seizures will stimulate brain cells to sprout new synaptic connections, and in some areas of the brain that are capable of nerve regeneration, we will stimulate neurogenesis. So there's that as a possibility. There's also clear data that suggests that we can reset the responsiveness of the hippocampus and the hypothalamus pituitary adrenal gland axis to make the brain more responsive and more receptive to circulating cortisol. In other words, to get, if you will, a better stress regulation response. So we could, to put it very simply, we could rewire the brain stress response through repeated induction of seizures. We also know that as you continue to induce seizures, the seizure threshold goes up. In other words, you change the excitability of the brain as you continue to induce these seizures. And if you change the excitability of brain regions like the anterior cingulate cortex or the hippocampus, or the prefrontal cortex, which are very much involved in mood, in depression onset and depression maintenance, you have a theory for how it might work there. And indeed, MRI studies PET studies have shown that ECT does change the metabolism of hippocampus and cingulate cortex. So to summarize, yes, it's a 1938 treatment that we could definitely refine some more, and yes, it does have risks, but it is the best in class treatment for severe depression, which itself is a very severe illness. And if we can match the technique to the right patient and do things to mitigate risk, we can help a lot of people get better and do so safely.